Hi everyone. Having discussed the DNA viruses, now let us go on with our journey of the RNA viruses, and the first one that I'm going to start off in this is the Myxovirus. Now how do we divide these Myxoviruses? They are divided into number one, the Orthomyxovirus, and the other family is referred to as the Paramyxoviridae or the Paramyxovirus family. Let me start one by one. I've started off with the difference between the two, and then we'll take up each organism individually. So the next thing that we have is orthomyxo versus paramyxo, and I know you want to first know the members of the family. So all of you must have heard of influenza virus. So where does influenza virus come in? So remember, orthomyxo is going to have that influenza A, B and C that we talk about, all the H1N1 and all of those things come under orthomyxo. Whereas what is paramyxo? We have something called, you've heard of a famous vaccine called MMR, isn't it? So the measles and the mumps. But now comes the catch. Many students believe since measles and mumps comes here, rubella also comes here. No, rubella is a different family. With R, I will make you learn respiratory syncytial virus. So respiratory syncytial virus comes next. If influenza was in orthomyxo, what influenza will be in paramyxo? Para-influenza will be over here. So the next member is going to be the para-influenza family. And then there is a zoonotic infection which is of late very, very famous, and that is the Nipah virus. So repeating once again, we've got influenzas under orthomyxo and everything else under paramyxo. Now talking about their size. So the Orthomyxoviridae family, roughly 110 nanometers. Paramyxoviridae family, which is a lengthier family, I can see more organisms under it. So it has a larger size, that is the 150 nanometers. Talking about the RNA, I think everyone remembers that all the RNA viruses are going to be unsegmented. That's the rule. All RNA viruses are unsegmented except for there was a mnemonic called BIRA. Remember, influenza virus is going to be segmented. It has a segmented genome. It was one of the exceptions. Talking about the nucleocapsid, I think again once everyone knows, I'll take you back to the general virology. Do you all remember there was a mnemonic called Mr. Fab? And Mr. Fab told you he is Mr. Fab. So he was for helical, and then there were a lot of organisms which were showing you a helical symmetry. Just for your revision, M was what? Myxovirus. So if I ask you what is the symmetry that you're going to see over here, we are usually going to see the helical symmetry in both of them. Talking about the envelope, are they enveloped viruses? Yes. Are they going to contain peplomers? Yes. What is the RNA sense? Negative sense, positive sense. The same Mr. Fab mnemonic was also for the negative sense RNA viruses. So this means Myxovirus is once again going to be negative sense and negative sense. I hope that is okay with everyone. So basically Myxoviruses come under the Myxovirus Mr. Fab mnemonic, means both of them have a helical symmetry and both of them are going to have a negative sense RNA. Chalo, this table is totally done. Now I'm going to take it up one by one. First I'll make you finish off the influenza A, B and C, and let us get going with this. As I've told you, it is a negative sense. Mr. Fab is negative sense, and I've told you it is segmented. How many segments? So I had made you learn a mnemonic called BIRA, in which I said that all the viruses that have a segmented RNA are going to be BIRA. So for B was for Bunya virus. I told you Bunya, B looks like 3, so Bunya virus had 3 segments. I was for influenza and I looks like 8. So I told you influenza has 8 segments. Ye khatam kar do. What is this? Rio virus. Rio virus had 3 plus 8, 11. It had 11 segments. And then we had arena virus that had 1 plus 1, that is 2 segments. Yaad aa gaya everyone? I told you that basic chapter is your most important chapter. So now how many for influenza? 8. Please note, influenza is of 3 types, A, B and C. Almost 8 is what I'll know. It is 8, 8 and the last one actually has 7 segments. So 8, 8 and 7 is what you should know. Now I'll show you a diagram. This is how an influenza virus looks like. All of us know that it is an RNA virus. So in the center there must be an RNA over here. Very good. RNA is sitting over here, not a problem. Now I realize that if I look at the outer layer, there is some yellow structures, and there are too many of them. बहुत सारे ये yellow structures हैं, and then there are some green structures also. So these too many structures that you have are hemagglutinin. Can I say hemagglutinin or HA are more in number? They are roughly triangular in shape, and what is their function? Why has God given them? These are the ones that will come and attach to the body. So they attach to which receptors of our body? they attach to the sialic acid receptors. Where are sialic acid receptors present? They are present on the respiratory epithelium and they are present on the red blood cells. So please remember, whenever influenza virus comes, we all know influenza matlab lungs mein. What is there in the respiratory lining? It is the sialic acid residue. Also, what is present? Where is it present? RBC. That is why I call it hemagglutinin. It's going to have an impact on RBC also. Okay, the more in number were hemagglutinin, and then there are some tiny mushroom shape wala dikh raha hai. This green color mushroom shape that you have, this is neuraminidase. So please remember, the next one, that is Na, is going to be neuraminidase. It is less in number. As you can see, it is going to be mushroom shape. And now simple, if hemagglutinin helped in the entry of the virus, this is my respiratory cell, hemagglutinin has helped in the entry of the virus. When new copies will form, who will help in the exit of the virus? That is going to be neuraminidase. So this is basically going to help in the release of the virus, and this is gonna be known as, that process I will tell you in 5 minutes. This is also known as RDE, that is going to be the receptor destroying enzyme. Just for few minutes you will have to do a ratta. I'll tell you in a while what is RDE, what is receptor destroying enzyme. It is also known as the sialidase. ये सब समझ आएगा when you do the pathogenesis. I promise I will teach you. So simple, hemagglutinin helps in entry of the virus and neuraminidase is going to help in the exit of the virus. Perfect. Now this is just one thing. Did you see some other labelings also? Can you see there is a coat called M1 protein and then there is some purple molecules called M2 protein. I'll show you a super enlarged version. Dekho. What you have in the center, these are the RNA. 1, 2, 3, 4, 5, 6, 7, 8. Yes, influenza has 8 segments. This is how I will identify in the paper. This is an RNA virus and I can see that it has 8 segments perfectly put up. Then the one that is in abundance, all of these are going to be hemagglutinin. The one that is mushroom shaped and less in number, that is neuraminidase. Then what I see is a covering which is over here. What is this? This is M1 protein, and then I see few scattered molecules called M2 protein. Now where is M1 protein present if I ask you? You will say, ma'am, this is envelope, and below the envelope this M1 protein is present. So M1 is maintaining the structure. That is what is the question over here. What is M1 protein? It is below the envelope and it maintains the structure. So envelope ke saath this is going to maintain the structural integrity of this particular virus. But what is M2? I'm not calling it M2. I'm calling it M2 ion channel. M2 is an ion channel which I will be using in the pathogenesis, and this is going to aid in the uncoating of the virus. When the virus will enter into my body, how will the virus uncoat? How will all the layers remove in my body? Because of this M2 channel. In a while I will also tell you a drug against it. So now I've told you everything. Na H ho gaya, N ho gaya, M1 and M2. Should we fit all of this in the pathogenesis? Let's get going. Guys, I've got you an influenza virus and you can see hemagglutinin, neuraminidase. You are very sure that this is an influenza virus that ma'am has got us. And ma'am had told us that the one that is going to help in attachment is going to be hemagglutinin. Hemagglutinin is going to bind to the sialic acid receptors. Exactly what we had studied. So step number 1 is going to be attachment. Like I told you, attachment is going to be between the hemagglutinin and the sialic acid receptors. Everyone's okay with this? Now what has happened? Okay, this virus has been brought inside. What has happened? The virus is internalized by, how is big words I'm using. It has been internalized by what? Simple, endocytosis. It has been internalized by endocytosis. तो यहाँ क्या बन गया? You will say, ma'am, simple, मतलब यहाँ पे बन गया endosome. There is an endosome form. I am not interested in all this. I am interested, remove the H, remove the N, remove M1, remove M2, remove everything. Get me the RNA. From the RNA, I have to make new virus particles. Uncoating. I want everything to get removed. So please note, there is going to be an uncoating. That is step number 3. So second was what? Second was getting it into an endosome. Fine. The third step is going to be uncoating. How is that going to happen? So now you will say that, ma'am, for the uncoating to happen, I will have to go back and take the help of the M2 channel. M2 channel matlab, this M2 purple, I'll show you on a higher part. This M2 jo purple channel tha, this is gonna allow the entry of acid, H ions. H ion influx is gonna happen, and that is how the virus is going to shed all its layers. If I am sending H into the virus, am I acidifying it? Yes. So can I say the next step is uncoating is done by what? It is done by acidification of the endosome. See, big words I told you na I will use, but they mean very simple. How have I done acidification of the endosome? I have done that by doing a H plus influx via which ion channel? Via M2 ion channel. Has everyone understood? Step number 1, attachment. To which receptor? Sialic acid receptor. Step number 2, internalized. What is the process known as? Endocytosis. Step number 3, remove everything, uncoating of everything. Uncoating is done by what? Sending the H positive inside. That is known as acidification. But I told you one thing, okay, very good, uncoating done, RNA has come out. Step number 4 is that this was a negative sense RNA. This is the first sentence I taught you. I'm not interested in a negative sense RNA. If I have to make more molecules, I need a positive sense RNA. I will have to convert it into a positive sense RNA. And how is it done? This is done by RNA dependent RNA polymerase. RDRP is gonna determine this. RNA dependent RNA polymerase. Step number 4 is done. Now new viruses are formed. Ab bas ek cheez. That is the 5th step. What is the 5th step? You have to release the virus. Guys, who was helping in the release? Neuraminidase was helping in the release of the virus. Did you notice something? This is a new virus. New virus matlab it has hemagglutinin also, it has neuraminidase also. You will say that, ma'am, hemagglutinin was for attachment. Why didn't the virus come back and get attached over here only? It had hemagglutinin. The new virus could have come back and couldn't gotten attached over here only. Why did it not do so? Because neuraminidase ka, I had promised you na, I will tell you one name. Neuraminidase is a sialidase. What will it break? The receptor, sialic acid receptor will be broken, so that again you can't attach to that particular cell. That is why I call it a receptor destroying enzyme. Neuraminidase is referred to as a receptor destroying enzyme or sialidase, so that these particular ones that we have, these receptors, they are destroyed. So I will call it as receptor destroying enzyme or neuraminidase. So let's do, if I have to write it down for all of you, can you do fill in the blanks with me? Number 1 step is what? Number 1 step is attachment. Attachment is going to occur by which molecule of the influenza virus? By hemagglutinin. On which receptor? On the sialic acid receptor. So by hemagglutinin on the sialic acid receptor. Perfect. So after that, how is it internalized? What is the next step? Next step is endocytosis. After doing endocytosis, what are you going to do? You're going to do acidification. There are 3 questions coming up. If you have to do acidification of the endosome, your first question is, why are you doing that? Ma'am, because I want only the RNA. I want uncoating. Question number 2, how are you doing that? Acid bhejna hai, to ma'am, I'm going to send H plus ions. I'm going to do H influx. Question number 3, from where are you doing this? You are sending it via the M2 ion channel. Coming to question 4. Question 4, or you can say the 4th point, says that you are now going to convert the negative sense RNA into a positive sense RNA by which enzyme? This I think everyone knows. It is the RNA dependent RNA polymerase. Finally, coming to the 5th one, and that is the release. The release is going to happen by which molecule, guys? It's going to happen by neuraminidase. What is the other name for neuraminidase? Receptor destroying enzyme. If you have to write it down and revise your bullet points, this is going to be it. So now can I say that if by chance I have to treat this virus, and if I stop the M2 ion channel, if this H influx does not happen, if acidification does not happen, so if this entire step only doesn't happen, then nothing beyond this will happen. So if you want the virus to be killed, or if you want the virus to stop and you want to treat the patient, basically target the M2 channels, and that is what has happened with certain drugs. Now we have targeting drugs against M2, especially only for influenza A, and that is amantadine and rimantadine. You must have seen these drugs being given in influenza. Why? Because what is the channel that they target? It is the M2 channel that they are going to target. Simple. Now let's move on forward and look at it under the electron microscope. Exactly what you had studied. This is how the influenza looks looks like, you are going to identify this by lots of segments in the RNA and by the HA and the NA that are projecting from the surface. That is how you would be identifying an influenza virus. Now let's go into the details. Please note there are 3 genera which I have been telling you, influenza A, B and C, but they will ask you what is the division based on. It is based on RNP. So that is a question. Influenza A, B, C is based on RNP. Let us study about them. So please remember, influenza C so you will hardly ever see because this is non-pathogenic. So you must have heard we have influenza A and B happening. Influenza A is going to be everything. Influenza A is a lot of things. So if you ask you, does it have a base in humans and animals? A for animals, animals may be hoga. What does it show you? It shows you a lot of things. I will just teach you the difference between antigenic shift and drift, and you will realize antigenic shift is more severe. So remember, sudden and severe. So that is going to be A wala associated with antigenic shift, and it is associated with both epidemics also, pandemics also. Like I told you, influenza A is the main one. Means it is going to have a base in animals also and humans. It is going to be responsible for antigenic shifts. It is going to be responsible for epidemics and pandemics. Whereas influenza B is बेचारा, it does not have any antigenic shift, सिर्फ humans में है, animals में नहीं है, and ये seasonal flu कराएगा, no epidemic pandemics. Now your next question I know is, what is antigenic shift? So remember the difference. This is something you study in PSM also, isn't it? The difference between the antigenic shift as well as antigenic drift. Now please note over here, S for S and D for D. Matlab, antigenic shift is sudden and antigenic drift is dhire dhire. Dhire dhire means very, very gradual. Antigenic shift is sudden and antigenic drift is dhire dhire. Let me tell you, rather than reading all this, it's difficult now. So let us see this directly with the help of a diagram. The first thing that we are going to study is an antigenic shift. So what happens is, for example, this is some kind of influenza virus, not A and B. Virus 1 keh lete hain. This is some kind of influenza virus. This is another kind of an influenza virus. They are the same, they are different, I have no idea. But both of them end up infecting the same animal or the same human being. So for example, if both of them enter into my lungs, or both of them enter into the pigs, or both of them enter into the birds. So for example, they have gone into the pigs, just as an example. Virus 1 also has gone into the respiratory tract of the pig. Virus 2 has also gone. What will happen between them? We will realize that because of this, there is going to be a genetic reassortment, and now a new type of hybrid will only form. Can you see it has little bit of purple color RNA? It has little bit of red color RNA. So दोनों का combination करके some virus C has only developed over here. Can you see that? So why has this happened? Repeating once again. Please note that this is an exchange of RNA segments between the two viruses. I can call it genetic reassortment. So this mixture can happen in anyone, like humans, pigs, birds, but most commonly the mixing vessels are said to be pigs. That is a question again. The most common mixing vessels for influenza are pigs. Like I said, just a genetic reassortment that is happening. I have already told you, shift is very sudden. S for S, shift is very, very sudden, very, very major. And I just told you it was influenza A which was having all major things. And influenza A was causing both epidemics and pandemics. So all about influenza A comes over here. Whereas what is antigenic drift? Antigenic drift is dhire, dhire, dhire. Very dhire, dhire, dhire it occurs. So what is antigenic drift? Now that's the next thing that you have to know. So it is just one thing changing. Means it is a mutation in H or N. Remember we did hemagglutinin and neuraminidase. Bas unme se kuch mutate ho gaya, like mutated hemagglutinin. If so, there's just one chota sa change that has happened and the hemagglutinin has undergone a mutation. That's about it. So this is not gonna cause any pandemic, epidemic. Ye seasonal flu type of things hai. This can be seen with any of the influenza. This is a very mild thing. So please remember, antigenic shift. Shift is S for S. Very, very sudden, very, very major because of genetic reassortment and mixing vessels. Antigenic drift is dhire, dhire, very gradual. Dhire, dhire, chota sa change, that is H or N getting mutated. No major epidemic, pandemic. Easy for everyone to learn, because now we can go on to, based on the H and N. Please remember, we have different kind of genera available. You must have heard type A H1N1, type B, or then H3N2, H5N1. You heard all of this, na? So remember, there are 18 on the basis of H and 11 on the basis of n, but there's a lot of controversy. If you see my own previous lectures, I have taught you there are 16 and 9. Now I'm teaching you there are 18 and 11. Basically with the influenza, everything is getting discovered on a daily basis. So this number is not important, because till the time you go for your exam, this number would have been changed itself. This much you've understood, that there are 3 genera, but I'll give you some example. You must have heard that in June 2009, there was a pandemic that was declared for H1N1, that was type A influenza. Influenza A causes epidemics and pandemics, isn't it? So H1N1. Other than that, in circulation we have H3N2, we have H5N1, we even have type B. Type C nahi sunoge, because I had told you type C is non-pathogenic, isn't it? And nowadays you must have heard that H3N2 cases are again on the rise after COVID. So these keep having a shift in there. Every 10 years there is an up and down that keeps happening. So what are the clinical features? Incubation period, just think of something like an influenza. It's gonna have a 1.5 day to 3 days incubation period, isn't it? So I can say it is gonna be 18 to 72 hours, 2-3 days maximum. That is the incubation period. Who is the reservoir? Humans to hai hi, but animals, birds, all of these are reservoirs, and that is the problem na, that this virus is taking so many mutations. Whenever animals are involved, it's a major concern. And what is the mode? I don't wish to teach you that what is the mode for influenza. Don't we already know that inhalations of droplets and coming in contact with fomites, even the general population, non-medicos after COVID know that basic influenza kaise spread hota hai. Okay, so what are going to be the clinical features? Again, the basic clinical features I don't feel like teaching you. There is fever, headache, sore throat, cough. Patient will complain of joint pains, muscle pain. You don't have to mug it up. You've experienced it probably. So ये तो prodrome है जो सब में होगा. But other than that, you need to know that, you know, when we are saying sore throat, cough, everyone assumes running nose hoga hi hoga. No, that is what I want to point out. Running nose is usually absent when you are dealing with a case of influenza. So read these kind of points rather than reading fever, sore throat, myalgia and all. Read these points, that running nose is usually absent, and rarely, even in although COVID is a different family, but even with COVID, because influenza ka hi type hai na, even with COVID you must have seen people were having diarrhea, people were having GI symptoms. So rarely GI symptoms are also been reported with it. Okay, what else? There are kids who are known to have Ray's syndrome. What is Ray's syndrome? Ray's syndrome is nothing but Jamshedpur fever. So that has been reported in kids as well. Along with that, in complications, because it's an influenza, we also know pneumonia is known to occur. But if someone asks you which is the most common extrapulmonary symptom that you have, and that is going to be myalgia. The most common extrapulmonary symptom, not cold, cough, pneumonia, extrapulmonary is myalgia. ठीक है, let's move forward. Going to the lab diagnosis, क्या specimen लोगे? Think of COVID only for that matter. सब कुछ influenza का you know from COVID now ना. So you know you're going to take a nasopharyngeal swab, and after taking that nasopharyngeal swab, firstly, what was, if this was the swab to take a nasopharyngeal swab, what was the the material out of which that swab was made? It was made of Dacron or polyester tips. Basically, we don't very commonly use cotton. We use Dacron or polyester tips. And do you remember after taking, they used to dip it in a vial, fluid hota tha. It is stored in VTM. VTM is nothing but viral transport medium. VTM is nothing but viral transport medium. So simple, you took a nasopharyngeal swab using a Dacron or a polyester tip, you dipped it in the viral transport media, it has basic factors for survival of the virus, and then you send it to the lab. But you say that ma'am, abhi lab is in some other state, it is going to take 1 day for the sample to reach the lab. So remember, if you want to, till 4 days ka time you have, right? So if you have 4 days before testing, you can store it at 4 degrees. If you have, ideally everyone has a lab available in their city, you put the testing of the sample on the same day, but just in case, then 4 days tak agar delay hai, you store it at 4 degrees. But even if you feel that no, the sample will reach the destination after 10 days, after 4 days, basically, if it is going somewhere, then you will have to store it at -70. So please remember, that is what is the same protocol that is followed for COVID samples also. COVID samples also, 3 days tak, 3-4 days tak, it is 4 degrees centigrade, refrigerator mein rakho. Beyond that, you have to put it at a -70, -80 and store it. ठीक है, so now what are you going to do with the samples? I think we all know we are going to do isolation. Come on, embryonated egg and influenza. I have taught you something. An embryonated egg had something called an amniotic cavity and it had an allantoic cavity, and in both of them we could have something to do with influenza. But I told you all the boys are very protective about their yari. कुछ याद आ रहा है? Yes, Yari. So remember, influenza protective vaccine was basically prepared in allantoic cavity, but influenza growth was going to happen in the amniotic cavity. Am I right? Let me check. Yes, it is gonna be, I want to grow the virus. If I want to grow the virus, I am going to use the amniotic cavity. If I would have had to make the vaccine, I would have used the allantoic cavity. Fine. Other than that, I told you na, that you are also going to use cell lines. Whenever you don't have an egg, you are going to use cell lines. For this, you can use the primary monkey kidney cell line. Monkey kidney cell line can be used, which is, I told you, monkey rhesus, monkey primitive hota hai, primates hote hain, so they are primary cell lines. See, again and again I'm telling you, your general virology chapter has to be very strong because that is 50% of this virology section. ठीक है, isolation is done. You want to do antigen detection. Antigen detection is always done by direct immunofluorescence. You want to do antibody detection. That is always done by ELISA. Nothing new, ma'am. Antigen by direct immunofluorescence. Antibody is always done by ELISA. But what is this that you have written? You have written it shows heme adsorption and you have written there is heme agglutination inhibition test. ये दोनों का क्या मतलब है? बिल्कुल. We will start studying about it and then I'll come back. तो चलो, let us study these three things once again. First and foremost, it shows you heme adsorption. Means what? Have I grown it on some cell line? For example, if this is a cell, I tried to grow influenza in it. You will say, ma'am, cell line mein influenza has grown. Don't you think that inside a cell, if influenza has grown, that influenza will start showing? I'll take these two pencils and I'll say one is hemagglutinin, one is neuraminidase. Every influenza will start showing HANA, HANA. HA is hemagglutinin. Will it start absorbing all the red blood cells? If I add any animal ka red blood cell, fowl red blood cell, sheep red blood cell, will they start getting absorbed? So please remember, if there is a growth, whatever growth will happen, to that, if I add some animal RBCs like fowl RBCs, do you think they will get absorbed? Yes, because they have hemagglutinin and they are going to show heme adsorption. So because of this hemagglutinin on the surface, the red blood cells, these fingers of mine, nails of mine, red nails, their red blood cells are getting attached onto them. Okay? This is heme adsorption. What is the antigen detection methodology? Direct immunofluorescence. What is antibody? Antibody ke liye we always go in for ELISA. We always go in for ELISA, but we don't go in for one ELISA. We usually tend to go in for paired sera. What is the meaning of paired sera, guys? Paired sera always means that you have to take two. You always have to take two samples and the duration between those two samples 10 to 14 days. So I have learned two sample 2 weeks. Okay? Two samples which are 2 weeks apart, and how much increase in antibody should you be seeing? There is a 4-fold increase that you should see between these two. So from first day after 2 weeks, the two samples that you've taken, in between them 4 times your antibody should have been increased for it to tell you that it is a significant ELISA. In most of the ELISA testings we do that because antibodies are non-specific. Remember, ELISA, paired sera, 2 samples are taken 2 weeks apart and a 4-fold increase is indicative. What is the last test? HAI. इसका क्या मतलब है? So let's study HAI. It is heme agglutination inhibition test. It is heme agglutination inhibition test. So what do I do in this? I take RBCs, sirf RBCs, and no virus is added, no antibodies added, nothing is added. You will say, ma'am, nothing will happen. If you only taken RBCs, after some time, those RBCs will say, Arey, I am tired, you are not giving any virus, no antigen, no antibody, kya karo? The RBCs, because of their weight, they will settle down. They will form a button. Button means no reaction. When no reaction is occurred, those RBCs will sit down at one place that acha kuch nahi ho raha, let me just rest, khatam. On the other hand, to these RBCs, I'm not putting anything from the patient right now, only I'm doing. First, I only took some animal ka RBCs, nothing happened, they made a button. Then to those RBCs, I added the influenza virus. I know that influenza virus shows you heme adsorption, heme agglutination. Do you see? Virus went and got stuck onto these. Have you resulted in a clump, in an agglutination? Yes, and that is what is going to show up over here. ये जो यहाँ पे दिख रहा है, this dark red color thing that has formed, it's looking like a mat. So when you see a mat or a carpet formation, this means heme agglutination has occurred. तो मैम ये तो पता ही था, this तो you've been telling me since 10 minutes that any influenza virus will show adsorption, will show heme agglutination. Patient कहाँ है? Now I'll do this. Now what I do, I take the same red blood cell, I take the same virus, and I take sample from the patient. So antibody जो लिखा है यहाँ पे, this is the patient sample. Here they have assumed that the patient got infected with the influenza and has antibodies. Let us assume that this patient has antibodies. Don't you think this time the antibodies will combine with the antigen, and antigen तो busy हो गया? Earlier the virus was free, that is why it was going and binding with red blood cell. This time the antigen has got a partner called antibody. Antigen-antibody reaction will occur. So will they have any time for going and sticking onto the red blood cell? No. So now can I say once again there will be red blood cells will be like, Arey, I'm waiting, no one is coming to me, let me just sit down and make a button. Can I say that initially the heme agglutination was occurring, but now the heme agglutination got inhibited? So if I see heme agglutination inhibition test as positive, that means the antibodies are there. Because the antibodies are there, they got busy with the virus. There was no one to take care of red blood cell. The red blood cells made a button. So that is what I've told you over here, that one of the antibody detection methods is ELISA, where you take a paired sample. The other one is going to be the very famous heme agglutination inhibition test. Next, you have two types of PCR. I'll write them together. There is something known as a RNA virus, so you will have to do a reverse transcriptase PCR. And at the same time, this has to be a real-time PCR so that you can quantify also. These are the two types of PCR that are performed, and in fact, you cannot ever take away the fact that these PCR will always be sensitive and specific. I could have done this in 2 slides. My purpose of doing it in 1 slide was I wanted your flashcard to be ready. What are the things that you're going to do for the influenza isolation? So first, you're going to take a sample. I've told you all the sampling techniques in 1 slide. You take a Dacron swab, viral transport media, 4 days, 4 degree, that is 1 flashcard. The second thing I've told you is if you have to isolate, you will isolate it either in the amniotic cavity or the monkey wala cell line. On the cell lines, it will always show heme adsorption. Antigen ke liye you will do DIF, antibody ke liye you will do ELISA. 2 samples of ELISA, 2 weeks apart, 2 2s are 4, so 4 time antibody titer. Heme agglutination inhibition test hoga, reverse transcriptase and real-time PCR will be sensitive and specific. That is your flashcard for influenza lab diagnosis, which leaves you with treatment and vaccination. It's very simple. So we have a very famous drug called Tamiflu, known as oseltamivir. Oseltamivir is given by what route? O for O. Oseltamivir is given by oral route. There is another drug called Zanamivir or Relenza. All of them have nasal in them, right? Zanamivir, nasal, Na, Relenza, nasal. So inhalation route. Basically nasal or inhalation route. So repeating, oseltamivir is by oral route and Zanamivir or Relenza is going to be by nasal route. Finally, I told you for influenza A especially, there were some M2 inhibitors, M2 ion channel inhibitors like amantadine and rimantadine. You know that. So what are they? Amantadine is M2 and rimantadine is M2. These are the M2 inhibitors that you have. What are the vaccines? So the most common vaccine is again a live nasal vaccine. You know, this has 3 strains. This was a lot in the news also, that this live nasal vaccine protects against, it's a trio-protection. It's a trivalent vaccine that is going to get protection against what all? 2 of them are influenza A and 1 of them is influenza B. So influenza B ho gaya, A mein the famous H1N1 is needed and H3N2. So H1N1, H3N2 and type B. These are the 3 things against it which provide protection. Remember, 2 to 49 years is the adequate age, so not usually preferred after 50. And contraindicated if there is low immunity, because this is going to be a live vaccine, so you can't give it to people who are immunodeficient. On the other hand, for healthcare workers especially, annually jo hota hai na, for healthcare workers, you have an inactivated vaccine in which 2 doses are given annually, not really followed in our country much, because we as healthcare workers know that I have never received this vaccine. So inactivated vaccine twice annually for a healthcare worker. Yes guys, with that we definitely wrap up our entire influenza family. So we are done with the Orthomyxoviridae, and now we are going to go on to the Paramyxovirus family and do these set of organisms. I hope you've understood over here. The most important point was number one, talking about the types, antigenic shift and drift, and definitely the pathogenesis and the entire flowchart. I hope you understood it. Let's begin with the next part of the Myxoviridae family, and that is Paramyxovirus. I hope you all have understood the Orthomyxovirus, which is the first part of this chapter. Now let's go on to the Paramyxovirus, and I want to tell you some one or two differences. Although if you look at the beginning of the chapter, I have told you all the differences, but now I'll show you the diagrammatic representation. So have a look at this. Under Orthomyxoviridae, if you remember, could you see that the genome was approximately 8 segments, right? So there was a segmented RNA that you could visualize over here. Whereas when you're coming to Paramyxoviridae, there is a single RNA. There is no segment that you see. It is a non-segmented or an unsegmented genome that we are going to have. Second, if you remember, in Orthomyxoviridae, one of the molecules that you had on the surface was hemagglutinin, and then the other one that you had was neuraminidase, right? Whereas if you see over here, in case of Paramyxoviridae, you will see that hemagglutinin and neuraminidase are on the same spike. They are on the same spike. So that is one thing that we see over here. Second, we see something extra, and that is known as the F protein. There is a protein called the fusion protein or the F protein, which is present in members of the Paramyxoviridae family. Now let's move forward. What are the things that are going to come under this? I think I've already told you. There is MMR to begin with. M stands for measles. Then there is measles virus, then mumps virus. Then everyone believes I'm talking about the vaccine MMR, but R is not for rubella. R stands for respiratory syncytial virus because rubella does not come under this family. Okay, coming to the next, para-influenza. For Paramyxoviridae, we have to think of para-influenza. And we also have Nipah virus, which is going to be discussed over here. So these are the different viruses that we need to know. I'm starting first with the measles virus because that is something you studied more commonly in pediatrics also. Now, what is the other name for measles virus? It is also known as rubeola. So I hope you know the difference between rubella, rubeola, measles, German measles. There's a big, confusion that they have created, and I will sort out that confusion for you. So whenever you're talking about measles versus there is something called rubella, so you have to do a cross connection. So remember, rubella is not rubeola. Rubella is different because the other name of measles is said to be rubeola. So you can't keep the two similar things together. So measles is rubeola and rubella is said to be German measles. Rubella is said to be German measles. So simple, keep the measles and the measles away, keep the rubella and the rubeola away. That is the rule over here. So remember, measles is known as rubeola and rubella later on will be known as German measles. Okay, what is the incubation period? Mostly in children, this is going to be 10 days, and for adults, it's a little longer, 21 days. Again, something which students have a problem in learning. So let us go for the vaccine. Your favorite vaccine, MMR, measles, mumps and rubella. So when you're talking about measles, mumps and rubella, and they ask you that what are the incubation periods of these particular viruses, first you're going to make a 10 because measles, as you can see, is going to be an incubation period of 10 days. After that, from that 10, you are going to make a line at the bottom. What does that become? For mumps, it becomes 19 days. Okay, then from that 19, what can I do? You will make a straight line. So for rubella, it becomes 14 days. Remember, it is 10, 19 and 14. So 10 may say you're going to make a line that becomes 19. Then you make another line that becomes 14. So 10, 19 and 14 are the incubation periods. That is why for measles, I wrote 10 days. What is the transmission? Measles is by obviously the respiratory droplets, which is going to be the inhalation of these droplets, and that is how it will get transmitted. So now let us know who are going to be the sources and what is the period of communicability. Basically, I'm also touching upon the PSM aspect. Source, of course, is going to be the case. The person who has been infected, a measles virus infected person becomes the case, and that is the source of infection, and there is no carrier state that is ever known. What is the reservoir? We. So simple. We as patients are the reservoirs. We as patients are the cases. And what is the period of communicability? So please remember, whenever the person has rash, from 4 days before the rash to 4 days after the rash, the person is in the period of communicability. Fine. What is the immunity with measles? This I'm sure you've heard, a lot, that measles has a lifelong immunity. That is why it's, once someone is infected with measles, that person is immune for a lifetime. But why is that so? Because that person is infected with a single serotype and there is only one serotype that exists. So once you get an immunity for it, you're always going to have immunity. Okay, if you've understood this, now let me come to the most famous question. The most favorite question that they have, the 3 C's. How are you going to pick up measles? What are the starting symptoms, prodromal symptoms? Of course, it's a fever, which every virus shows you, but it's the 3C which you have to be which they're very fond of asking you. So what is this 3C concept? There is cough, coryza and conjunctivitis. So remember, these patients have cough, coryza and conjunctivitis. That is something that came in the recent 2023 exam also, which is very important. So cough, coryza, conjunctivitis, please watch out for that. Moving on to the next one. This was only your prodrome, because now what is the actual first manifestation out of all of these? Out of these, fever is the first manifestation, and we know that fever occurs on the 10th day. Now you will keep adding 2 days, 2 days, 2 days. So 10th day par kya hua? Because what was the incubation period? The incubation period was 10 days. So on the 10th day, that is the first day of the symptomatology, what is the condition? Fever. Now what happens after that? After that comes the most famous spots called the complex spots, which are seen by the 12th day. And after that, you see a rash, which is seen on the 14th day. So if I ask you what are the 3 days in which this goes on, remember it is going to be fever on the 10th day, complex spots on the 12th day, and rash on the 14th day. Now let me elaborate on this. Fever, you don't need any elaboration on, I'm sure, but you would want to see what are these complex spots. So these are the pathognomic complex spots that I'm seeing over here. And where do you see them? You can see them near the molars. And remember, how many days? So you will remember, ma'am, 2 days you were adding. Pehle you were seeing fever. So roughly 2-3 days later, you are going to see the complex spots, and roughly 2-3 days later after that, you will see the rash. So it is seen on the molars. It is seen on the molars 2 to 3 days after fever. But how do they look like? Molars ke paas to theek hai, but how is it looking like? So if you look very carefully, there is a white color dot, and surrounding that white color dot, there is a reddish base. Hai na? So what did I say? There is a white color dot, and surrounding that, there is going to be a reddish base, and that is the description that you have. A white spot on an erythematous base is a complex spot. Ho gaya. Now what after complex spots? You say after complex spots, 2 to 3 days later, you're going to see a rash. Of course, we are going to see a rash, and this is usually a maculopapular rash. So firstly, if you look carefully, where is it beginning? So just imagine it's Holi and someone throws a bucket of paint or a bucket of watercolors on top of you. So how is that bucket of water going to go down? So first it will start from he's thrown it on your head, over your head. So first it will start from behind the ear. So where does the rash begin? You can see over here, the rash is going to begin from behind the ears. After that, you can see that it has come all the way onto the face. So from behind the ears to the face, then it goes to the rest of the body. Then it follows the rest of the body. So from behind the ears, then the face, then how it goes into the rest of the body, and then it starts disappearing also in the same order. It starts disappearing also on the same order, but this is the rash that has occurred. But you know what happens? Now please remember, when the rash appears, then the fever and complex spots are gonna run out. The fever and the complex spots are going to disappear with the appearance of the rash. That is a very famous line that is written in all pediatrics books. So we say that the rash is quite a dawn. When the rash comes, everything else is gonna run away. So coming all the way back, when I told you this concept, that fever on the 10th day, then complex spots on the 12th day, and rash on the 14th day. So when the rash is basically present, at that time, the fever and the complex spots disappear. Very, very important information that you have. Now, a lot of pathogenesis has gone into why is this rash happening? Itna kya dawn hai, they did a lot of stories and studies on it. So they said, ye kaun sa dawn hai, that when this dawn has come, everyone has run away. So what is the reason for the rash? There are 2 things that are said. Number 1, it is said it is probably an antibody-mediated vasculitis. So antibody mediated phenomena hai, and why are they calling it vasculitis? Because they are saying that maybe that is why it has those red kind of spots, so it's a vasculitis. Some say no, it's not antibody mediated, it is probably a T cell mediated damage. So there are lots and lots of theories which are going on around it, and yes, you should be knowing. So antibody mediated and T cell mediated damage, and that is what is going to be the measles rash. Oh yeah, fever, spots, rash. What are the complications? The secondary bacterial infections, especially in the form of respiratory infections, ENT infections. Matlab, in the ears there can be otitis media, in the lungs there can be pneumonia. So remember the secondary bacterial infections, because it's a virus, now on top of a virus there could be a bacterial infection. Second, it could involve different organs. Due to measles, GI involvement can occur. There can be involvement of the brain, there can be involvement of the lungs. So everywhere there are different terminologies mentioned. So please remember that due to measles, there can be association with diarrhea. Due to measles, please remember there can be association with diarrhea. Also due to measles, there can be association with the pneumonia, and that is a very famous pneumonia. Do you remember? What pneumonia is it that is caused in measles? It is the Hecht's pneumonia. And Hecht's pneumonia is going to show you some cells, which I'll tell you in a while. I'll give you a hint. Hecht's pneumonia is also known as the giant cell pneumonia. So do you know what are the giant cells that you see in measles? Yes, what are the giant cells that you see in measles? It is going to be the Warthin-Finkelday giant cell. If you remember, I had shown you this giant cell in your general virology chapters, also in pathology. So here you have a giant cell, and inside it you have lots and lots of nuclei. Lots of nuclei. So inside it you have nuclear inclusions. You will have some ... in the nuclei, you will have some ... in the cytoplasm. So if you look carefully, this is the nuclei, lots of nuclei I can see, and I will appreciate that there are some dots in the nucleus and there are some dots, random dots in the cytoplasm. This basically means that Warthin-Finkelday giant cell has intranuclear and intracytoplasmic inclusions that are present. Intranuclear and intracytoplasmic inclusion. So coming all the way back, yes, that is the giant cell pneumonia or Hecht's pneumonia that I'm talking about. Coming to the CNS manifestations, there is something known as a post-measles encephalitis that can be associated with it. And there's another condition which is quite deadly, that is known as SSPE. So let us now get down to these two things. What is post-measles encephalitis? So obviously this is going to occur post-measles. So what happens post-measles? There is going to be antibodies which are formed against the, look at the protein, against myelin basic protein. Now common sense lagao, if there are antibodies against myelin, myelination will be affected, demyelination will occur, patient will land up with encephalitis. So the reason for the post-measles encephalitis is a myelin basic protein getting damaged. What is SSPE? First you should know the full form of it. It is subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis. So what do I have to know over here? That this is gonna be a very late. See, the name is only so lengthy, na? So it occurs after many years. So for example, if patient had measles, so roughly you can say 7 to 13 years later, this is a complication that it will occur to. But once it occurs, within 1 to 3 years, it ends up being fatal. So if it sets in, it is definitely going to be very deadly. So repeating guys, measles occurs, measles ke bahut saal, 10 years and above they say that SSPE occurs, but once it occurs, it is very quickly fatal. I hope you all remember from your medicine that this is going to be an effect that is going to occur. So what all is going to get deteriorated? There is deterioration of motor functions also, cognitive functions also. Motor and cognitive functions both are affected. And now that you've done medicine, please tell me that if you do an EEG in an SSPE, what is the pattern that you obtain? You obtain the burst pattern. The burst pattern is obtained over here. So these were the CNS manifestations. If there are antibodies against myelin basic protein, it is post-measles encephalitis. Then there's a very late but a deadly complication called SSPE, which shows you deterioration of cognitive and motor functions. Of course, if it affects the pregnancy, there's going to be effect on the child and it can result in intrauterine death also. So these are all your measles ka complications. It can occur because of some other bacteria coming in and causing ENT problem. it can occur because of measles only that can cause your pneumonia. So you will realize that there are two pneumonias in measles. One of the pneumonias is because of measles, measles causing pneumonia. That is what I've given a fancy name. And then one pneumonia is there is some bacteria that comes and causes on top of it. So you might feel, why has ma'am written pneumonia separately twice? This is a pneumonia because of some bacteria coming in, superseding infection. This is a pneumonia which is because of measles, and this has been given a fancy name. Okay, now all your manifestations are done. You're ready for the lab diagnosis. What do you think is going to be the sample? So because this is something which has an inhalation and respiratory droplet route, and there is cough, coryza, all these things, nasopharyngeal is definitely going to be the best route. And you know it's a virus. I'm not going to have any culture media. I'm going to have cell line. You can use any cell line, but they say that Vero cell line is highly recommended. Vero cell line is been recommended by CDC for measles. So do you know what is Vero? Because I have taught you this in your general virology. You might have forgotten by now, or if not, very good. So what is Vero? Vero is what kind of a cell line? Vero is a continuous cell line. And please note that this, I had told you, Vero is derived from, Vero is nothing but an African monkey. It is derived from an African monkey. So please note, monkey wala cell line measles को grow करेंगे, ठीक है? Monkey wala cell line measles is gonna be grown. Sorted? Okay, now coming to the next. It is an RNA virus. What kind of a polymerase chain reaction will I do? And we know PCR is the best thing to do. So what is it going to be? RNA virus, reverse transcriptase, understood. And what is the cytopathic effect? This we've already studied. The famous Warthin-Finkelday giant cells is what we are going to see under the microscope. Quickly showing you, Warthin-Finkelday giant cells show you intranuclear and intracytoplasmic inclusions. Coming to the vaccine, what is the vaccine ka strain that is used in India? So now you will always have a problem between MMR vaccine. As we think about MMR comes common, measles, mumps, rubella. So measles, the way you say measles, from today onwards you will write measles like this. And measles is going to be Edmonston-Zagreb strain. So that is how I have learned it. Edmonston-Zagreb strain is what is the one that is used in India, and that is what you have for measles. That is what you use for measles vaccine. So is there any side effect? You will say yes. The side effect is there could be, once you give this injection, give this vaccination, there could be a mild measles-like disease that the child is going to have, but it's just because the vaccine is made from the same strain, right? So mild measles-like disease hoga, nothing to worry. However, what could be deadly is a toxic shock syndrome. Why? Does measles cause toxic shock syndrome? Does the vaccine cause toxic shock syndrome? No. Please remember, if the measles vial gets contamination of the vial with what? Think, who causes toxic shock syndrome? Staph aureus. If the vial gets contaminated with Staph aureus and that injection has, or that vaccine has been given to a particular person or a child, then the child can have TSS. So it's not the TSS happening because of measles. It's the TSS happening, toxic shock syndrome happening because of contamination with Staph aureus. And now I will also tell you gradually what is for mumps and what is for rubella, what are the strains. I'll give you mnemonics. But before that, measles ke liye Zagreb strain is important. So measles is done. Shall we move on to the next one? And that is going to be mumps, because now we can probably know a lot of things about it. So tell me something, who is the source of mumps? Now, whenever you think of mumps, think of a cute little kid, because it's going to be something that is happening in children. So the source is of course going to be the cases. The reservoir is once again going to be the humans, and the immunity is once again going to be lifelong. I got these 3 points because measles may be we were the sources, we were the reservoirs, and immunity was lifelong. Mumps may be we are the sources, we are the reservoirs, and the immunity is lifelong. These are common points. Aage badhte hain. What is the age? I just told you this is going to occur in a cute little, I told you, think of, I'll give you a story also. When you're talking about mumps, think of a very cute little kid called Jerry. Okay, there's a kid. I'll show you his face. This is the picture of that kid, and that kid is named as Jerry. So have a look at Jerry over here. So say hi to Jerry. This is Jerry, who has this cute little, architecture of his face, which I'll explain to you why he has it. So that is what you have to know about mumps. Mumps is a cute little 5-year-old kid. What is the incubation period? Come on, you know this. For measles, mumps and rubella, I told you one mnemonic. Measles ka 10 tha. For mumps, you had to make a 19 out of it. So what is the incubation period? It's going to be 19 days. And what was for rubella? Rubella mein aage jaake you will make a 4 out of it. So it's going to be 14 days. Okay. What is the transmission? Once again, the transmission is going to be by droplet or saliva. So this cute little kid called Jerry, he is going to have infection with droplet or saliva. You will see that this is very commonly seen in the winter and the spring season. In the winter and the spring season, mumps is something which is quite often noted. What is the period of communicability? Whatever symptoms the child is having, remember from 1 week before the symptoms to 1 week after the symptoms, there is a period of communicability. Measles में क्या था? Measles में rash से था. Rash से 4 days before to 4 days after. Mumps में क्या है? Whatever symptoms I'm going to tell you, 1 week before to 1 week after. That is the period of communicability. Okay, but what is the infection that this cute little Jerry is going to have? So firstly, if I ask you what is the most common, you will say inapparent. The most common manifestation usually goes inapparent. If it has to show a manifestation, then the most common is going to be bilateral parotitis. That is the most common manifestation. That is why now you understand why Jerry had this cute little chubby architecture, because there is a bilateral parotitis. There's a bilateral parotitis that is noted over here. So now you will wonder something before I go on to the remaining parotitis. You will say that, ma'am, right now if I try to correlate the things, you told me that the infection is going to be via droplet or saliva. Droplet. So droplet means it's going to go into my lungs. If it was supposed to go into my lungs, how are you saying that the parotid gland is affected? Quite a valid thing if you had your logic going well, which most students shut down while reading micro. But if you have that logic going well, you should have thought about it, that why did that happen? So please remember, the mumps that is there, that is only going to multiply in the lungs. It is going to multiply in the lungs, and after that it is going to spill in the blood and go to different organs. It is going to go to different organs. So I can say lungs are only being used over here. It's use and throw kind of a thing. So they go into the lungs, they're going to multiply over there, they go into the blood, and then they're going to go to the parotid and to many other organs which I'll tell you. And that is what, so this child is quite naughty, na? Child is never. So what does this child do? Child Jerry is playing in the lungs, and after that he says, I'm tired of playing. Children get bored very easily. So he says, I'm bored, I'm tired, now I want to go somewhere else. Goes into the blood and goes into different organs. And one of those organs is the bilateral parotitis. There is one very important clinical dictum that you see, that these patients can also complain of pain, and this pain is increasing on consuming citrus juices. It is increased on consuming citrus juices, right? Now I'll give you one clinical dictum which will help you a lot in surgery and other subjects also. Whenever there is a bilateral parotid gland involvement, you have to ask or look out in the question for two things. Number one, if it is a child, the infection that you are going to think of is going to be mumps, which is in front of you. If it is an adult and that adult has come out to be a chronic smoker, there is a salivary gland tumor that you have to think of, and that is a Warden's tumor. I am not saying that this is like 100% correct. This will definitely not be 100% correct in clinical practice, but MCQ में ठीक पक्का होगा, because clinical practice has variations. That's what the human body is. But definitely it's going to be a big savior when it comes to your MCQs. Bilateral parotid gland involvement in a child is going to be thinking of mumps, and in an adult smoker is going to be thinking, you're going to be thinking of the Warden's tumor. So coming back, this cute little Jerry, either he did not have anything, or the most common presentation he had was a bilateral parotitis. But what is the second most common manifestation that he has? Is unilateral orchitis. So there is involvement of one-sided testes, unilateral orchitis. And does this lead to any problems with sterility? So please remember, this does not lead to sterility. This does not lead to sterility. Okay, after this you are going to obviously think of ke orchitis, unilateral orchitis to boys wala ho gaya. What are the other things that it can have? So can it have oophoritis in females? Yes, something in females also. So oophoritis in females. They can also have pancreatitis, and guys, brain involvement. Aseptic meningitis is also possible. In fact, so much so, there is a condition which is known as atypical mumps. There is a condition called atypical mumps, and atypical mumps means directly there is going to be meningitis. Imagine One of the starting presentations is going to be meningitis, and this meningitis is going to be without parotid involvement. Without parotid involved, directly there is going to be a case of meningitis. Very, very important information. That is why it's atypical. I expected first parotid and then later on brain. Yahan direct brain involvement and there is no parotid involvement, and that is atypical mumps. So finally, now what do I do for Jerry? I have to do the diagnosis. There is nothing in diagnosis that I can tell you. Every time we do antigen, antibody we do by ELISA. It is an RNA virus, so I'm always going to do RT-PCR. There is no culture possible except for cell lines because it is a virus. So for mumps, there is nothing new that I can tell you suddenly when it comes to the lab diagnosis. You know, this antigen, antibody, cell lines and RT-PCR is going to be copy-pasted everywhere. But what I can tell you is for the vaccine, what is the recommended strain? Why have I been naming this kid as Jerry? Because this cute little Jerry is going to use the Jerry-Lin strain. The Jerry-Lin strain is going to be the recommended strain. So let me ask you, what was the strain that you had for measles? For measles, you had the Edmondstein-Zagreb strain. Edmondstein-Zagreb strain is what was used. What do you have for mumps? Mumps is a cute little Jerry kid. So that is going to be the Jerry-Lin strain that is going to be used. And soon I will teach you about rubella, but not in this chapter. So I'll tell you right now, rubella ke liye it is RA27/3 and that is what is used. Okay? So now coming back, is this, as I told you, what we give together is going to be measles, mumps, rubella. Nowadays, measles, mumps, rubella and varicella is also given. That is also something that they have added as another vaccine that is available. So guys, measles is done, mumps is done. You know I'm not taking up rubella over here because it does not belong to this family. But what belongs to this family is the respiratory syncytial virus. If you honestly ask me, ma'am, what am I supposed to learn in 3 sentences about RSV? Let me tell you. Then I'll tell you all miscellaneous stuff. When you're talking about respiratory syncytial virus, you need to abbreviate it as RSV. There are RSV A and B, in which RSV A is said to be more severe. That is point number 1. Then of course it is going to be respiratory. So there is going to be rhinorrhea, there are going to be cold and all those respiration tract wala involvement. And syncytium means giant cells. So on microscopic examination, you see giant cell formation. Honestly, this is the most important thing to learn. But I will also add for you over here R for RSV, R for rainy season. Bas itna yaad kar lo, this is your last day flashcard. Respiratory syncytial virus, respiratory involvement, R for rainy season, syncytium means giant cells, and A wala serotype is more common, more severe actually. Now let me tell you the rest of the story. So if they ask you the epidemiology, I've told you what is the season in which you see it. It's going to be the rainy season. What is the age group? It is a very young child, 6 weeks to 6 months. Mode, of course, respiratory hai, so it's going to be an inhalation and touching of objects like fomites. I've told you it's got 2 subclasses out of RSV A and B. RSV A is the one that is going to be more severe. Coming to the clinical features. In infants, this is one of the most common causes that you have of the lower respiratory tract infection, and in adults, it causes more of upper respiratory tract infection. So please remember, children may, especially the fever type that you see or the clinical features type that you see is fever, there is rhinorrhea, there can be cough, there can be difficulty in breathing, that is dyspnea. There can also be wheezing. There is involvement of the lower respiratory tract. So a lot of features can be seen with regard to the lungs. In adults, it is usually an upper respiratory tract infection. So if by chance, now I say that you have to do the diagnosis of respiratory syncytial virus, you will say, ma'am, first start copy pasting the things which you always tell me. You always tell me there is going to be an antigen, there is going to be antibody detection, RNA virus hai, so I will do reverse transcriptase PCR. And finally, you will say there will be some cell line which I will grow it on. And here I use the HeLa and Hep2 cell lines. Again, which kind of cell lines are those? Those are continuous type of cell lines. Finally, the word that I told you, syncytial, means what is the cytopathic effect, or what is it that you're going to see under the microscopic examination? And that is going to be the syncytium formation. Syncytium matlab multinucleated giant cells. Multinucleated giant cell is what you're going to have. So what is a syncytium? Syncytium is going to be a cell which is going to be lots and lots of nuclei inside it. Like all of us have made a syncytium or a study group where we come together. So that is a sensation and the name only has it. So you'll never ever have a confusion. Coming back to what I told you, if you know pretty much everything that I told you respiration kuch hoga, I explained that. Syncytium you have understood. R for rainy season you have understood. Now you need to go on to the treatment. So there are two things. Please remember there is a newer drug which is available known as the palivizumab, which is there. It is of course a monoclonal antibody that we have. But for severe infections, there is something known as ribavirin, right? And out of these, please note, ये जो नया वाला drug आया, because ribavirin is known since a long time. But again, you can learn for respiratory syncytial virus, there is ribavirin that is there. But what is this about palivizumab that you have? So please remember, this is going to be against the fusion protein. Do you remember, guys? I told you Paramyxoviridae family has a fusion protein. So this is actually against the same. And that is how it is used for fighting the virus. Now, what all have we done? Measles, mumps, RSV is done. Then next we have two things, short ones, parainfluenza and Nipah virus. So when I talk about parainfluenza, quick, we'll try to finish it off just in one slide. So this is going to be seen more in the winter months. What all does it cause? One of the most common symptoms, just like influenza tha na Orthomyxoviridae mein, this also causes common cold. But in children, it's one of the most common causes of croup. What is croup? Laryngotracheobronchitis. I'm sure you've read about this in your ENT lectures. Laryngotracheobronchitis ka most common agent is going to be parainfluenza. So that is, something that it causes in the beginning, but in severe cases, it can lead to pneumonia also. But if you ask me what is the most common complication, that is going to be otitis media. So just 1, 2, 3, 4, bullet-wise questions are coming and you have to sort it. Quickly, parainfluenza ka question number 1, like any other influenza, what is the most common manifestation? That is going to be cold. Children mein kya karata? It's the common cause of croup, but if it gets severe, it's going to also cause the involvement of the lungs, lower respiratory tract, that is pneumonia. And finally, what is the most common complication? It can involve the ears, and that is otitis media. Okay, 4 questions, nothing about lab diagnosis of parainfluenza, because by now I am also tired. Wahi antigen, antibody, RT-PCR, isolation, nothing new or specific about it. Let's move on to the next one, and that is the Nipah virus. Before I start and give you so many bullets about it, maybe I can help you with a mnemonic, and that way you will be able to correlate this a little better with me. When I'll be talking about the Nipah virus, I am very something that is nervous. Why am I nervous? Because first and foremost, the nervous system is what is going to be affected. And secondly, I'm very nervous because this has a 60 to 70% mortality rate. So yes, I'm very nervous about the system also, and I'm very nervous about the mortality also. Next, the P will tell you that you have pigs as the amplifiers over here. Pigs are going to be the amplifiers. Also, you will be knowing P say you are just going to make a chota sa B out here, because there is going to be fruit bats. Fruit bats which are also going to be used in the life cycle. Finally, I'm saying A to H means this is an infection which can come from animals to humans. So that is what is Nipah virus. I'm very nervous about this virus because of the system affected and because quite a high mortality. Pigs are the amplifiers. P ka B kara, fruit bats is what I'll be seeing in the life cycle, comes from animal to humans. So now let's start reading. What is Nipah virus? When did it become a celebrity after the outbreak that happened in 2018? What is the mortality? I just told you there's quite high mortality, 60 to 70%. And what are the clinical features? I told you nervous involvement. So fever ke saath what is going to be there? Encephalitis. Diagnosis, do you want me to answer which PCR? RNA virus mein ma'am har jagah keep writing reverse transcriptase PCR. The only thing you want me to know is how is the life cycle gonna look like. So look at this over here. I can see pigs, and I've told you pigs are going to be amplifiers. So yes, this can come via pigs, but the main vector that you have is the fruit bat. So if the bat's urine ends up contaminating the food and water, that is how this is. So you can see these are bats which are somewhere near the fruit trees, right? So fruit bats ka agar urine, if it ends up contaminating the food and water, that is one thing that it can come to us via. It can also come to us via the amplifiers, that are the pigs, and the patient's secretions are also something that are going to be infectious. So over here, exactly, I feel that there is nothing about Nipah virus that you should be learning from anywhere else except this mnemonic. Like I said, nervous system, the patient has features of encephalitis. Also, what is very nervous, I am very nervous, is patient is going to have a high mortality. Pigs are going to be the amplifiers. Fruit bats are going to be the vectors, and of course I could see in the life cycle it is an animal to human transmission. Baki lab diagnosis everywhere, antigen, antibody, cell line, RT-PCR, that goes as it is. Yes guys, with that we wrap up the family of the, in fact we wrapped up entire Myxovirus. The orthomyxovirus is also done, that was everything about the influenza family, and then now we've also finished the Paramyxoviridae, the measles, mumps, RSV, parainfluenza and Nipah virus. I hope you guys have understood the Myxoviridae family. Let's move on to the next one in the class of RNA viruses.